Hi, everybody. Forgive me. I moved over the weekend and I am currently painting my new house. So I am a little dressed down for the last webinar of this webinar season. But we are so excited to end the year with 2021 updates from Dr. Scott Munsterman on E&M coding guidelines. Forgive my mess in the background. It is a big mess. You can only see a part of it. So anyway, Dr. Scott Munsterman is a speaker who is no stranger to this webinar series. In fact, he helped get us through the early days of COVID, and now he is going to wrap up the year helping us to better understand E&M coding guidelines for 2021 so that after all of you have a restful and relaxing holiday break, promise me y'all are going to get some rest and relaxation, that y'all will be prepared for the changes in January. Hi, y'all. Okay, so without further ado, I'm going to go ahead and let Dr. Scott Munsterman take it away.
Welcome everybody. My name is Dr. Scott Munsterman here with ChiroArmor, and our topic today is evaluation and management coding for 2021. Now there's some changes that are occurring in how to make the evaluation and management coding selection. And so we're going to talk about that. But first of all, just so everybody understands that the CPT codes that we talk about and the descriptions and the other data are copyright of the 2019 American Medical Association. All rights are reserved, and CPT is a registered trademark of the American Medical Association. And so let's talk about evaluation and management services. And of course, we all know and understand that it's important to define an episode of care. And we've had this conversation before, whereby an episode of care is all about establishing a beginning and an end to care, and then managing the patient's care in between. And active treatment versus maintenance therapy. Having a treatment plan, of course, is required for active treatment. Once the patient reaches their endpoint of care, which is defined typically by goals in the patient's progress and or maybe a plateau to a maximum therapeutic benefit level, then we know that that patient is released to maintenance therapy and wellness care. And Medicare is very clear in how they define that, but the essential component here that we're going to talk about today is really on the beginning of that episode of care, and it's all about that initial visit. And we know as clinicians that we have various components that we work through on that initial visit from an evaluating process, as is understanding the mechanism of trauma and how that was established and that onset of those symptoms, what brought or history taking through understanding the mechanism of how it occurred, our examination, any imaging, diagnostic procedures, and the results of that have brought us to a point where we have a number of clinical facts to think about. Well, we're going to talk about medical decision making because in this process, one of the ways that we can move forward with understanding how to code E&M coding, there's one or two routes that we can take, either medical decision making or basing it on time. While that medical decision making component is very key and very important, understanding all the things that we had to comprehend and digest, if you will, that we're going to talk all about that. And then, of course, we have our informed consent. We've got the problem DX that we arrive at, and then our treatment plan is built. And then, of course, signing the note, very key at the end of that whole visit. And so as we think about that evaluation and management visit, we have to think about it in its entirety, and then also appreciate the thinking process that we go through as clinicians when we are faced with all the facts, clinical facts of the patient and what we've arrived at. And like we mentioned, the examination being very key to that whole component in addition to the history, and going through all of the regional examination findings and understanding that we have to have all those documented, that they lead us to the point of a diagnosis. And so our current system of evaluation and management coding has been built on the 1995 or 1997 guidelines. And of course, there are 7 different components to that system, the way that we've been doing it. And as we can see, the history, exam, and medical decision making have been key components. Contributory to that up to this point has been the nature of the problem, time, counseling, and coordination of care. And we also know that based on our previous evaluation and management coding, and this is just simply an example to acquaint us with how we've been doing it today, or how we're supposed to have been doing it today. 99202, expanded problem focus, 6 elements in 1+ body areas. And so there have been components that we've needed to address and or bring forward out of our history taking, out of our exam findings, to be able to qualify today for those E&M codes. Well, beginning on January 1st, 2021, we can choose to document evaluation and management services using either medical decision making or time. And so let's dive right into that whole process, because we have to step back now and move away from the way that we have been thinking about coding, evaluation, and management, right or wrong, if we've been doing it the right way or the wrong way. We want to make sure that we get it right beginning January 1st. And right off the bat, what they did was they deleted 99201. And the reason that they deleted 99201 is because 99201 and 99202 are considered straightforward medical decision making, and currently largely differentiated by history and exam elements. And so at this stage of the game, they have eliminated 99201 simply because it was very similar, as they looked at it from a medical decision-making perspective, to 99202. And so our evaluation and management codes for our new patients throughout our established patients as well, 99202 through 99215, we have the capability to base that coding either on medical decision-making criteria, which we're going to talk about, or the total time personally spent by the reporting practitioner or the clinician on the day of the visit. I'm going to be very, I want to emphasize that, and we'll emphasize it even further towards the end of this discussion, that it is clinician-based and it's on that specific encounter date. But we're going to learn that total time includes face-to-face and non-face-to-face time. And as we've talked about through our essential components of that initial visit, we talked a bit about medical decision making, and the overall determination about medical decision making hinges on complexity. The complexity and number of problems or diagnoses, the complexity and amount of the data that we review, that we need to interpret and understand and digest, and then also taking a look at the complexity of the risk taking of the presenting problem, what diagnostic procedures may need to be ordered, what kind of management options to treat the patient are going to be selected. And so it's these 3 areas: the number and complexity of the problems or diagnosis, the amount or complexity of the information that we get, that we learn about, whether it's external information or information that we learn from the history and from the examination and our diagnostic procedures, what we learn from all that. And then wrapping up, understanding what is the risk to the patient, what is the complexity. Those 3 things lead us to the point of understanding, is this a straightforward problem? Is this a problem, or excuse me, is this a coding that is straightforward? Is it a low complexity visit, moderate complexity, or high complexity? And so our medical decision making is based upon those 3 key areas. Again, problems, the information that we get or the data, and then the risk. And so that leads us to ask the following questions about that. And so from a clinical perspective, we have to ask ourselves, well, how many problems exist and what is the complexity of each problem? How much clinical data did we need to process to intake this new patient or on this re-eval visit? And will there be any risks associated with management of the patient's problem? And so let's take them one at a time so that we can appreciate and comprehend each specific area. And let's talk about the number and the complexity of problems addressed at the encounter. And so how complex is the problem? Well, first thing we have to ask ourselves is, what is a problem? We can never assume that we know what a problem is. Well, a problem is a disease, condition, illness, injury, symptom, sign, finding, complaint, or any other matter that's addressed at the encounter with the patient, with or without a diagnosis being established at the time of the encounter. And so this would include consideration of any further testing or treatment that may not be elected at that particular point in time. And it could be that there's another medical professional or another provider that is actually managing the case or managing the problem without any additional assessment or care coordination that could be documented. I mean, this is not necessarily a diagnosis, but a problem is that sign or that finding or that complaint that the patient brings in. And so the various components of complexity then of that problem as we think about it. And of course, the amount of these problems is significant as well. But let's look at the complexity. We've got minimal problem complexity, self-limited or minor problem, acute uncomplicated illness or injury, acute complicated injury, stable chronic illness, and then chronic illness with exacerbation, progression, or side effects of treatment. And so what is a minimal problem? Well, a problem that is a minimal problem that may not even require the presence of a clinician or other qualified healthcare professional. And so a minimal problem could be something very simply resolved by simple advice, or things that they even may be able to, the patient may be able to solve themselves. A self-limited or a minor problem is a problem that runs a defined course or prescribed course of treatment. It's transient in nature. It's not likely to permanently alter their health status. So an example of this would be low back pain without leg pain. It could be acute, it could be subacute, but it's a easily resolvable problem. It's self-limited. It'll run its course. We treat it, and it's resolved, and the patient's happy, and they move on with their life. Then we have the acute uncomplicated illness or injury, and this is a recent or a new short-term problem with a low risk of morbidity, and there is little to no risk of mortality with the treatment, and a full recovery without functional impairment is expected. And so this is a case. It could be a strain injury that could cause an acute low back pain situation and diagnosis without leg pain, but it's more of an injury that is not complicated and will resolve. And so very low risk, again, of morbidity or mortality. Then we move on to the acute complicated injury. Again, what are we talking about here? We're talking about the problems and complexity of problems. Well, an acute complicated injury is one that requires treatment that includes evaluation of body systems that may not directly be a part of the injured organ. We look at a review of systems. We look at past family medical social history. Our history of present illness becomes involved because the injury is fairly extensive, and so it causes us to move forward into that realm more to make sure that we are understanding everything about that patient, because it is an extensive type of an injury. And so a good example of this would be a strain sprain injury resulting from a motor vehicle accident causing acute neck pain with radiation into the arm, headaches, loss of neurological function, nerve compression types of issues, disc types of issues that could be going on. More complicated injury that is associated with that, and again, there may be a risk of morbidity, meaning that there could be some permanent impairment that could result from this type of an injury. And so that's an acute complicated injury. And then we have the stable chronic illness, and that's a problem with an expected duration of at least a year, or it could be long-term for the patient. What's an example of that? Well, chronic recurring low back pain complicated by degenerative disc disease. That could be a good example of we know that we have a patient that has chronic recurring issues that flare up at times, requiring treatment at those times. But can we fix the degenerative disc disease at a specific level? And I think we know the answer to that. And so as we move forward with these patients, we know that they have a chronic condition that is stable but may require treatment or maintenance therapy during that time. And then, of course, we have the chronic illness with exacerbation, progression, or side effects of treatment. And that's a chronic illness that's acutely worsening, poorly controlled. And again, that's that chronic condition getting out of hand. So acute low back pain with radiculopathy, complicated by that degenerative types of issue, maybe complicated by chronic pain syndrome. But you get the idea that what we're dealing with here is a chronic condition that has acutely flared up or progressed and has become demanded much more clinical attention during the course of that time. And so again, based on the number and the complexity of the existing problem or problems, we need to define the problem's level of status. And so in order to find that level of status for this particular category, now we're talking about complexity of problems in medical decision making, we have our straightforward, low, moderate, and high. And so straightforward is minimal complexity characterized by one self-limited or minor problem. Our low 99203 level, as we think about coding, is two or more self-limited or minor problems, or it could be one stable chronic illness or one acute uncomplicated illness or injury. Moderate level problem complexity, which would be in the 99204 range, 214 range, could be one or more chronic illnesses with that exacerbation, progression, or side effects of treatment, or it could be two or more stable chronic conditions, or it could be one undiagnosed new problem with uncertain prognosis, or one acute illness with systemic symptoms, or one acute complicated injury. And then high level 99205 would be one or more chronic illnesses with the severe exacerbation, progression, or side effects of treatment, or one acute or chronic illness or injury that could pose a threat to life or bodily function. And so as we think about the complexity of the problems, the straightforward, the low, and the moderate may be more in our wheelhouse as chiropractic clinicians. And so the number and complexity of the problems addressed at the encounter, in categorizing them in that level of complexity, as we take that patient on, we do their history, we do their exam, we understand the problem better, the complexity of the problem, then we're able to determine which one of those categories that patient would fit in. Then we move on to how much information did we have to take in to understand the problem and understand what's going on with the patient. And so that's the second category of discussion that we need to take into consideration in this medical decision-making process. And so essentially, we're just asking ourselves the question, how much clinical data did we have to process in order to get that done? And so some of the information, as we think about that, I mean, certainly we had our history and we had our exam and our diagnostic, but there may be a time where we would be independently interpreting a test by another professional, whether it's some lab tests that in an external report that we're able to get those lab tests, or we're able to read the x-ray actually images themselves, or the MRI images or CT images, but we can have our own independent interpretation. And there are times when we can report those services separately, that professional component separately. And so one of the benefits of these new E&M code changes is that it may give us an opportunity to be able to read outside tests, images, but we need to pull it together in our own report and document that within our records, and then go ahead and utilize the -26 modifier when you report that on a claim form and bill for it. But there's opportunity for us to be able to take out that interpretation and that understanding and create a separate billable service. And it'll be interesting to see how insurance companies respond to that moving forward. Then we have what's called an independent historian. You know, and again, what are we talking about here? We're talking about all the information that's coming at us, and I sometimes call those fastballs. You know, we've got, you know, like I said, our findings that we're thinking about. We have some of these other things, independent tests, that we have to evaluate and think about and maybe write a report on. Then we have independent historians, which are those folks that come along with the patient. It can be their spouse, it can be their best friend, or one of their children, or maybe a sibling. And they're with the patient to help the patient get there, but also tell the story about what happened to the patient, because many times the patient doesn't give us all the information, and that's why they have brought somebody with them. They have a caretaker or a guardian or a parent, and it's that individual that brings another fastball to us as clinicians. It brings another avenue of information that we have to think about. And so that's part of the medical decision-making process. And then, of course, discussion of management. There are times, and we all do it probably almost every day, where we have to pick up the phone and we have to call maybe a provider that the patient has seen in the past, or maybe we have to pick up the phone and say, hey, Dr. Sally, I've got this patient in, 34-year-old male, and here's what's going on. Have you seen this before? But discussion of management with other providers is another element in the medical decision-making process. It's another element, time factor, as well, as we think about the overall picture of what has to go on in our minds as we work through the process of assessing what's wrong with the patient, taking in not only the work we've done clinically in the findings and the clinical facts of the matter, but also what is out there from the outside, or in the case of an independent historian, what are some other avenues that this data, this information is coming at us, and how complex is it, and how far do we need to go in our thinking process? Well, as you can imagine, there's straightforward coding when we think about this category, and that would be minimal to no data that we had to actually process aside from our own. There is a low level, which would categorize in the 99203, 213 range, and that would be tests and documents that we would consume. It could be a review of external notes, it could be a review of the results of a unique test, or it could be ordering of a unique test. So 2 out of those 3 would meet this requirement. Or if there was an independent historian that came in with the patient on that evaluation and management visit, it would automatically qualify it then as a low level of complexity. Now, moderate level of complexity is again meeting one of 3 requirements. The first requirement has to do with all the tests and documents and whether an independent historian was involved. And so reviewing any external notes or reviewing tests from a unique test or results from a unique test, ordering a unique test, or having an independent historian. So 3 out of the 4 of those would qualify for a moderate level, or having to do an independent interpretation of tests performed by another provider or another clinician, or discussion of management. So if you had to pick up the phone and call a colleague or call a medical colleague, chiropractic colleague, and talk about the patient, then you are at the moderate level of complexity for complexity of data in medical decision making. If you had to independently interpret a test that was done by somebody else and you've documented that, that alone stands alone as moderate. Otherwise, you're looking at reviewing external notes, reviewing results from a unique test, maybe ordering a test, ordering x-rays, ordering a scan, ordering lab work, and again, independent historian. So 3 out of those 4. So there's a variety of ways that you can get to that moderate category, again, based on that medical decision making. And then as is reflected earlier on in the complexity of the problem, that 99205, or that high complexity, really has a lot to do with exactly what we've just talked about, with the exception that you need to meet 2 of those requirements. So you would need to have done an independent interpretation of tests performed by somebody else and discussed management with somebody else, or having the 3 out of the 4 that we talked about earlier, with an independent interpretation or with discussion of management. And so it's a higher level of complexity, involves reviewing more information, but then going forward and either interpreting that into a report and or with discussion of other types of other provider types in terms of in understanding how do we move forward with patient management. So what have we talked about at this point? Well, we're talking about medical decision making, right? And we talked about, first of all, the number and complexity of the problems addressed at the encounter, and the levels of complexity based on, is it an injury or not an injury? Is it chronic, and is it exacerbated, or has it been aggravated and progressed, and all of that. So we talked about that complexity of the problems. We just got done talking about the complexity of the data and the information that we take in on a daily basis on these evaluation and management visits. Maybe there isn't anything that we've had to take in extra, but then in some cases there is a lot. There's external reports. Again, we may pick up the phone and call another provider and discuss the patient management with that provider, previous provider, or maybe somebody that we need advice from, interpreting the tests that have already been done. And so the amount of data needs to be analyzed and reviewed and looked at and judged. Okay, what complexity was that at? Well, that leads us to the third category of medical decision making, and it's based on risk of complications or morbidity or mortality of patient management. And so we have to ask ourselves, will there be any risks associated with the management of the patient's problem? And what do we mean by that? Well, whenever we go through a history and go through an exam, we kind of end up with, boy, I need more information. I need some x-rays on this patient, or maybe I need to refer this patient out for an MR scan or a CT scan, or maybe there's other diagnostic tests that need to be performed, and we need to make a referral. Maybe it's just making a referral to a surgeon right off the bat, or somewhere to the ER or whatever. But we're making a decision that there's something that we need to do with the patient now, whether it's further diagnostic procedures or it's treatment. And as we think about risk, one of the things about risk is that it's the probability and consequences of something that's going to happen, of an event. And so we have to assess it by the nature of the event that we're considering. And so if it's a treatment procedure, what is the risk of that treatment procedure? If it's a diagnostic procedure, what's the risk of that diagnostic procedure? Well, we don't have to guess at that. What we do, though, need to do is that we need to refer to the table of risk. And CMS put this out, and this is the most updated version here. You can click on this link, go to it, download it so that you have it readily available. January of 2020 is when they updated it, and it lays out in this table the level of risk. It lays out the presenting problem, and that should look familiar to us, right? We talked about complexity of problems, and so it helps lay out that complexity of the problem. And then it goes on to talk about the diagnostic procedures performed, and it talks about the management options selected. And so let's say, for instance, we have a presenting problem that is an acute uncomplicated injury. All right, this is one of those injuries we refer to as a low back strain sprain injury. It's going to be resolving with treatment. Maybe we treat the patient for 2 weeks, 3 weeks, a month, whatever the case may be, and they're good to go after that. What are the diagnostic tests that may need to be ordered? What is the treatment that may need to be selected? Well, as you can see, physical therapy being very low level of risk, very similar to what we do, occupational therapy, physical medicine. And so our treatment as chiropractic clinicians will fall into this management option selection, which would be the low level of risk. However, if we're moving into a more extensive injury, let's say it's an acute complicated injury, then we need to look at, okay, what diagnostic procedures are going to get ordered or could potentially be ordered, and what management options could potentially be selected. And all of a sudden that diagnosis, that complex problem, more complexity to the problem, will lead us or could lead us into a moderate level of risk. All right, and so we have to take a look at that. We have to think about that as we assess the level of risk. And then, of course, the high being the presenting problems we've talked about, and then, of course, the diagnostic procedures that could potentially be ordered. And we're into more of higher end, more complex medical types of issues. And so as chiropractic clinicians, we will be looking primarily into the low level of risk, minimal, maybe possibly minimal level of risk, but it's going to be more low level, potentially moderate level, depending on the types of presenting problems that we are faced with patients. And one thing I wanted to bring to mind here as well is that they've added social determinants of health as a moderate level of risk. And of course, what this refers to is that our diagnosis and treatment could be significantly limited by social determinants of health. Well, what are those? Well, those are economic and really social living conditions that can influence access to care. And so we could be talking about food insecurity or housing issues or transportation issues or a lower socioeconomic status from a financial perspective. There can be barriers that can be barriers to access of care or the type of care that the patient may need. And if we sense that, if we understand that, and that becomes a fact in the case, if you will, for this patient, then that becomes a social determinant of health and can bring a moderate level of risk to the patient from a management perspective. And so based on the risks associated with the patient management, we have to define the problem's level of status. And so now we go back, and we look at, is this a straightforward problem? And that would be minimal risk of morbidity from any diagnostic or treatment procedures that are provided. Low risk, that would be a low risk of morbidity from any diagnostic procedures or treatment. And again, that table is what we reflect on. Moderate level, as we talked about. And so an example of moderate level would be, and remember we talked about it can be that acute complicated injury scenario. The types of treatment could be prescription drug management that could be going on, or some minor or elective surgery, or it could be, again, the social determinants of health have become a part of how that may complicate the patient's recovery on the management side of it. And then the high level, what are some of the high level? Well, that's drug therapy requiring monitoring and blood testing, maybe surgery with certain patient risk factors that could be involved, emergency procedures, hospitalizations. All of that is more seen as that higher level of complexity and higher level of risk based on the table of risk. There, we've talked about the three categories, of medical decision making, and it's kind of, it may be a little bit overwhelming to have to think about it in that manner, but it is what we do every single day with patients. It's all there. This isn't anything new. We're doing it. When we assess patients, this is the information that we are consuming and digesting and thinking about and arriving at a conclusion. And it's just sorting it all out, if you will. And I, for one, like how they laid this out, because it shows how valued our thinking process really is in this whole gig that we took on as clinicians in examining and diagnosing patients and treating patients. All right. And so we have our complexity of problems and how many of those there are. We have our amount and complexity of the information we have to take in and understand and then spit out, if you will. And then we have the level of risk, whether it's the diagnostic procedures or the treatment procedures that could be recommended for that type of complexity of problem. And so let's think about now, okay, where do we go from here? Now we have to figure out the code, right? And what we're going to actually do. Well, let's say, for instance, that the complexity of problems that we have is low. So we have one acute uncomplicated illness or injury, all right? And let's say that we had to review some information. We had to order some x-rays, we reviewed results of some tests, we reviewed external notes, and that brought us to that moderate level of complexity of information, which is not out of the ordinary, right? But then as we thought about, okay, what do we need to do with the patient? We know what the problem is, we understand it, we went through all this work, if you will, to understand that, but I'm going to be able to treat the patient. Sally's going to go along just fine. I'll probably treat her for 2 months or maybe 2 weeks, whatever the treatment plan is. And, I reasonably expect this condition to resolve. Well, that would be a low risk of morbidity because our treatment is very low risk. Okay. And so let's look at that though. What do we code that visit? We arrived at these decisions, acute uncomplicated illness or injury category of Sally's problem. We had to consume a fair amount of information, but we got through that and we arrived at this is going to be a low level of risk. So how do we figure out what code to use? Well, to calculate that final E&M code, to qualify for a particular level of medical decision making, 2 of the 3 elements for that level of medical decision making must be met or exceeded. And so as we think about the number and complexity of the problems being low, the amount and complexity of the data being moderate, but the risk of complications being low, 2 of the 3 being met is low. And so we would code this a 99203, or if it was on a progress eval that we went through the same thing and we re-examined or an established patient, or it's a new exam on an established patient, it'd be a 99213. And so that's how we go about understanding making those medical decisions and to what level and how we arrive at a code. Now, the AMA has put out, I would recommend that you download this, use this as a cheat sheet, and that should be helpful. It talks about the code, it talks about the level of decision making, talks about the complexity, it talks about the complexity of data that you had to consume, and then the risk of complications, and it lays it out fairly well and succinctly there for you to use as a cheat sheet moving forward to help you through. And we talked through each one of those columns to give you a good idea as to what you're currently doing today and how it sorts out in making a decision based on medical decision making, which E&M code you should utilize. So now we're going to shift gears, because remember we talked right away early on about medical decision making and that's one route we can go to determine which E&M code to utilize. And again, this begins January 1st, 2021. We got to understand this, get it under our belt. Well, if you don't have sufficient complexity to code by medical decision making, then you have an alternative. And of course, what is that alternative? Well, that alternative is documenting your total time for that E&M visit. Okay, so what does that mean? Well, that would be, total time is defined as that face-to-face time that we have with the patient on the date of the encounter, and it also includes the non-face-to-face time on the date of the encounter as well. And so what is, and by you, the clinician. Okay, so let's make sure that we get this right. It's not staff time. It's not anything to do with anybody else other than you, the clinician, with the patient on that day, and that would be face-to-face time, or you on that day that you see the patient, the date of the encounter, and maybe you had to review something before you went in and saw the patient. Maybe you had to make a phone call. Maybe you had to review after you saw the patient. All right, well, let's talk about all those little steps, because as we think about it, it ends up being a lot of things. And so preparing to see the patient, that's part of your total time. Obtaining or reviewing anything that could be separate in regards to history. Maybe they brought something in. Maybe there are some medical records that they brought in or that you are able to get access to that you're reviewing on that data service. Certainly performing your history and your intake work and reviewing that intake work becomes a part of the total time. And the examination that you perform, the time you took to do that. Counseling with the patient. So what's a good example of that? Well, what about the report of findings you do with the patient? When you get done with your examination, and if you are doing some diagnostic procedures, you certainly are providing a time then with the patient and saying, okay, Sally, here's what we found. Here's what that means. Here's your alternatives to treatment, and we discuss informed consent at that time, right? And then we lay out, well, here's your treatment plan. Here's and we talk about goals with the patient. What are their goals? What are some good goals? You decide that. What is the frequency of care? What does the duration of care look like? What are some self-care? But we have that conversation with the patient, and we call that our report of findings. Well, that's counseling and educating the patient and or the caregiver at that particular point in time. There may be time on that date of encounter that we had to pick up the phone to order an MR scan or maybe a CT or lab work, or we had to call and talk to another provider or get some advice or whatever, or referring the patient. Maybe we had to get on the phone and refer the patient, but it's our clinician time that we are doing. In addition to that, and I hope you're sitting down, but it also includes documenting clinical information in the electronic health record, or documenting it if you don't have an electronic health record, documenting in your paper file. It takes into consideration total time, takes into consideration your time as a clinician to get that date documented, but keep in mind that we're talking about the date of the encounter. And so if you don't do your notes until the day after or the week after, which believe me, that is not desirable, you need to do your notes on that date of the encounter in order for you to be able to document your time for as total time for documenting in the clinical record, whether it's in your EHR system or paper, but that is inclusive of total time. And then if there's any independent interpreting of results, or you have to communicate those results, pick up the phone again and call the patient, hey, we got this in, and on the date of the encounter, that gets included in the total time. And so it's fairly encompassing. But again, where you're restricted is on the date of the encounter. We know that sometimes we're not going to get all the information in outside of or within that date of the encounter. And this is a rub right now, and I think you'll see more definition of that throughout the preceding years to come, that we will hopefully see some give on that. But currently, that's where the guidelines are at when it comes to coding, that it is on the date of the encounter at this point. And of course, as we think about all that's been said about this, and think back to when we first started this conversation about how we're doing things today, well, no longer is an element in the selection of an E&M code, part of like, I did this in the history, I did, a review of systems, and I did a past family medical social history, and I did 6 elements here and 4 elements there. I mean, we're not talking about any of that. What we're talking about, though, is a higher level of work that we're doing and how it's organized through the medical decision-making process, or based, again, on time. And so that leads us down the road to understanding something that does not change, and that's making sure that we have clear and concise documentation, that we're documenting to our standard of care, which is dictated by your licensing board in your state. And this isn't all about reimbursement. This is about performing to the standard of care. Now, the only way anybody can know if you perform to the standard of care is through what? Your documentation. And so you can mitigate malpractice risk, you can validate your coding, your treatment plan, and again, it guards against any types of wrongful billing that could occur. So total time, what are we looking at here? Well, under a new patient, 99202, based on the AMA guidelines, you're looking at 15 to 29 minutes, a 212, 10 to 19 minutes, 99203, 30 to 44 minutes of time, total time. Again, we talked about what total time means, and that can include your documenting in your EHR system, would be inclusive in that total time element if you do it on the date of the encounter. All right, let's make sure we're very clear. And again, this is total time is your time, not anybody else's time on the case or for the patient. It's your time that you put into the case, face-to-face and non-face-to-face on the date of the encounter. I sound like a broken record, but it's so important that we get that principle down. 99204, 45 to 59 minutes. Of course, 213, 20 to 29, 214, 30 to 39. And so these are the time frames for those codes. And again, documenting your time, what you did on what. The more you document, the better when it comes to documenting your time in your record, in your documentation. And we didn't say anything about 99211, and the reason being is that this code, the use of this code, does not require you to even be present in the room. So it's not a code that you're going to do service for and bill for. Your time and your effort, if it's an E&M, even at a straightforward decision-making process, your minimal code is 99202 or 99212. as a clinician. All right, so always keep that in mind. Understand what these codes are used for, and if it requires you or not. Another thing that hasn't changed is what is a new patient, and that's somebody that's not received any professional services from a clinician or anybody else of the same specialty who belongs to the same group practice within the past 3 years. Of course, established patient is one who has received services within the past 3 years. And always keep in mind that a new patient has nothing to do with a new injury or maybe a new insurance or financial class the patient may in. It has nothing to do with that. It has everything to do with, have you seen that patient before within the last 3 years, or another clinician in your group, same specialty, has seen it, and so seen the patient. And so keep that in mind. Couple last things here before we tie up here. There is a prolonged visit CPT code for the time frame. So if you do exceed the 205 or 215 level of time, as we talked about earlier, that you can report at least 15 minutes more additionally in these prolonged visit codes. And so let's think about the key points here. So again, document your diagnosis, the amount of data that you had to consume, the activities, accurately assign the medical decision making and time levels depending on which route that you go. How will you think about that? Well, conduct a little bit of an analysis as you think about that. And you have to think about your workflows and the time you take consistently throughout the day. Is it a better representation of what you do with the patient because you do spend a certain amount of time with everybody? Or is it a better representation of your work, the things that you do, and you maybe move at a quicker clip, but you get a lot of work done that could be counted within the medical decision-making route versus time. I mean, you simply have to figure out how do you roll throughout the day. And you may choose time for one patient and medical decision-making for another, but it's all about the work that you do or the time that you're allotting, and then taking a look at it from that perspective. And so understanding, will the patient encounter allow you the efficiency to work through clinical activities in less time to achieve a higher level of coding than if you just use the total time? So, maybe you spent 25 minutes and you were able to code in medical decision making a moderate level at a 99, 203 or 204, that would be, versus that 25 minutes, being at a 99202. And so that's how you need to take a look at it, because you're doing work. Are you doing it in a shorter amount of time than not, or do you spend more time because there may be more discussion but less medical decision-making components? And so that's kind of what you have to think about, because each patient's a little bit different, but you'll be able to decide by that patient encounter, what is it going to allow me to do? Am I going to be spending more time talking to Sally, but I don't have a lot of medical decisions to make here, but it's more listening and talking and all that, versus it's a shorter conversation, maybe a shorter history, but I've got to review this and review that, and I'm able to work through that. So you have to think about that. Secondly, to think about is, will your EHR system help you document medical decision making or time to validate your coding selection? These systems should be helping us. Okay, they should be making our life easier to document and help move us down the road of maybe even giving us some advice, which I'll show you an example in a minute. And then we have to understand too, what will be the impact on my practice revenue with the change in the coding? Is there going to be any impact in my practice revenue? So this is just an example of an EHR system that advises currently today, based on the 95-97 guidelines. It actually goes into the record and pulls out this coding advisor and says, hey, you met this, you met the requirement of the HPI, you met the requirement of the RIUS systems, past family medical social history, you performed this many exam items. We're recommending that you do a 99214 for this visit because it meets those components. This is simply an example of how EHR systems should be helping us to understand, okay, we do have our bases covered and we are documenting well, and I could do medical decision making, and that's where you look at, hey, I've met those requirements. If I billed for time, it may be a 99213, but I met the medical decision making requirements to bill a 99214. Which one are you going to go with? I know which one I would go with. You make the decision. I want to be paid for my work that I do, and I think you need to be paid for your work. You do a lot of good work. Let's get paid for it, but make sure that you document it, do the work, and make that happen. So whether you use time or medical decision making, we have to make sure that we document the medical necessity, and again, all of those components that are relevant to what the way that we went about deciding which code we were going to use, medical decision making route or time route. Now, the last thing we're going to end with here is that there is a consequence to these changes, which you maybe have heard a little bit about. We came out well over a year ago when we read the proposed rule that, this has been talked about for 2 years, by the way. And because they're making these E&M code changes, it changed the relative value unit, which applies to all procedures across the board for reimbursement, and in particular for Medicare. Now, whether other payers, insurance companies, are going to make these changes in their systems or not remains to be seen. Potentially they could, but just so that you understand that the impact to Medicare services will bring down the fees, the fee schedule for chiropractic services, as it will for a number of other providers. There are some winners and there's some losers, and we happen to be on the losing side of seeing that our RVU values have and will decrease because of the way that this is getting reweighted. The evaluation and management codes are actually getting reweighted. And so Medicare, in their proposed rule back in 2018, they're looking at proposing a payment that would be the same for your codes, your E&M codes, like your 99212, 202, and 203, 204, 205. You can see, and those numbers in red, they were all proposed based out of the previous ruling that they had. And so as you see that come forward, don't be surprised. Of course, Medicare does not reimburse chiropractic clinicians for any E&M visits, but the reason I'm telling you this, and the reason we want you to know this, is that you may see changes in your other reimbursement patterns moving forward because of these E&M code changes. And so here are all the references. We've done a lot of homework for you, but we always recommend check our work, check the work of other consultants. These are the links that you can go right direct to. You can learn all about it. And we're certainly open for any questions or comments. If you would like to reach out to us, we're happy to visit with you more. And I just want to thank you for your time today, and thanks for all the good work that you're doing. And again, one of the bright spots that I see as I look at this, I think this is a forward movement to better understanding the clinical work that goes into taking care of patients on the front end, and being able to demonstrate that. I think this is a positive value from that perspective. And so again, if you have any questions, feel free to reach out to us. Been great being with you here today.
Okay, everybody. Now y'all can see bigger of my mess and that light. Okay, anyway. So, yes, I'm emailing the link. So when you get your email in about an hour or two, it's going to have a link to the webinar recording. It's going to have a link to the handouts so you can download them at that time. It also has the links that he showed on that last slide that says here are all the references. So anyway, y'all will get everything you need so y'all can be prepared. And again, that webinar link never expires, so feel free to watch it as often as you need to. Share it with your team. Man, that is really bad. Sorry, guys. I'll have the whole office set up before our next webinar in a month. So I just want to say thank you so much for being a part of the webinar series and for watching all this year. And again, we will not have another webinar until January the 12th. And it's Stop Chasing Your Money with Dr. Alan Berquist, Dr. Nathan Unruh, and Brandy Brimhall. We've got a lot of exciting webinars coming up. We're going to have some stuff updated all the way into the first quarter. And then we're making some exciting changes to the webinar series in 2021 as well. Trying to shorten them just a little bit. So little smaller chunks of information for you guys so that, you get some rest and relaxation and are not just trying to inhale lunch while you're watching this and trying to learn and multitask. So smaller chunks that you actually get a break in 2021 at times with just, 3 or 4 bullet points that we can hit. So lots of good stuff coming in 2021. I hope you all have an amazing holiday and a happy new year. And I cannot wait to see y'all back on January the 12th from a new office that will not be storm, cloudy skies, gray, and also not a mess. So anyway, see y'all soon. Bye, y'all.